So to moderate the session, I call upon Dr. Gannet Gabramedin. Dr. Gannet Gabramedin is a graduate of University of Gondar. She completed her OBGYN specialty training in Black Lion Hospital, and she did her fellowship in urogynecology in Jumma University in collaboration with Lyon University in France. She is currently a faculty at St. Paul's Hospital Millennium Medical College. So I call upon Gannet to moderate the first session. Thank you.
Thank you, Dr. Matthias, for your generous introduction. Our first research topic today is impact of COVID-19 responses on SRH service provision, and our presenter is Samuel Moulier. Samuel Moulier is a research and evaluation advisor in IPAS Ethiopia. He has MSc in biostatistics and MA in project management and BSc in statistics, with more than 10 years of experience of managing various researches, monitoring and evaluation, and data management projects. Samuel Moulier has also strong experience in improving capacity for routine monitoring and evaluation, research and reporting, including working with Ethio-Canada MNSH project at St. Paul Hospital, and he's also an monitoring and evaluation advisor. He has also a great contribution at EPHI as a data management and analyst consultant, and he was at Arbaminch University as a lecturer. Currently, he is in IPAS. He provides technical oversight of to monitoring and evaluation activities, and he has led SRH researches in research design. I call upon Mr. Moulier to present his research. Please come to the stage.
Thank you very much, Dr. Gannet, for inviting me to present our research. And also, I would like to say thank you for organizers for organizing this kind of very nice RH symposiums. And also, I would like to thank the scientific committees for selecting our research for oral presentation. Now I would like to present our research. The research is conducted by IPAS. So just I'm here by representing IPAS. The impact of COVID-19 response on RH care service provision and utilization in Ethiopia. This research is conducted in 10 sub-Saharan countries, but now I'm trying to present only our findings. This is a preliminary analysis, and I'll try to present our country findings. From the background, the emergency and rapid spread of COVID-19 has led to a dramatic shift in national, regional, and global priorities. All countries battle to slow or stop transmission, provide care for those infected, and minimize impact of epidemic on health and healthcare services. Even the response to COVID-19 has seen shifts in health priorities, including financing, programming, and also with negative impacts on access to and provision of SRH service. COVID-19 measures to general populations may potentially amplify vulnerabilities and also in some cases increase poor SRH outcomes and well-being. So we need to evidence on the impact of COVID-19 to support decision making. The main objective of this assessment is to document the overall impact of COVID-19 pandemic on availability, assess utilization of reproductive health in Ethiopia, and we try to specify some objectives. In these objectives, we tried to describe the effect of COVID-19 pandemic on the availability and use of reproductive health service for women and young girls. And also we tried to examine how organizations and service sites have adjusted their reproductive health service provision amid COVID pandemics. And also we tried to assess how women and young girls are assessing reproductive health service in the context of COVID-19 pandemic and at the end of the specific objectives, we try to describe shifts in funding landscapes and impacts of such changes on SRH service delivery. Here, the method that we employed to analyze this researches, we used a cross-sectional mixed method design. This mixed method design was a convergent parallel mixed method, which means all methods have equal values, and we try to conduct the whole techniques like we use qualitative and quantitative simultaneously. We gave them equal values because that is a convergent parallel mixed methods, and the analysis also presented parallelly. So the assessment was conducted in Amhara region and Addis Ababa city administrations. Thank you. Okay, now I'm trying to present the key findings. As I told you, our method was a convergent parallel mixed method, and our findings try to present the whole method parallelly, and we try to see the findings from quantitative and qualitative. In the first, let's try to see changes in SRH service provision due to COVID-19 pandemic. From the interviewed, we found that at the initial phase of COVID-19 pandemic, especially on April to June 2020, except NC and delivery service, all other SRH service had almost been discontinued. And also consequently, most women and young girls have stopped taking SRH service from health facility, and uptake of SRH service dropped dramatically during the specific periods. Close to half or 48% of health facilities reported that they were not handling their patients in the same way they used to before. And also significant proportion of service providers have indicated that the service provision has been affected by changes of like in the referral patterns. Like 29% of facilities reported that they changed our referral patterns, and 23% of the facilities reported that there was a change on commodity stockouts, and also 20% facilities also reported that there was a change on service delivery time. And we tried to assess what protective measures was taken at the facilities. And as we can see from this graph, the last one, social distancing, it's not only social distancing, including wearing masks, hand washing, and sanitization. These four protective measures were imposed almost in all facilities in that pandemic period. Limits on patients' volume, 21% of the facilities and also the other specific days for service, around 23% of facilities reported that they used this specific days for service as a restriction or protective method, and totally or partially cease of services also seen around 15% of health facilities, which means this situations may happen or extended for 2 weeks, around 2 weeks. For around 2 weeks, some facilities reported that partially or completely ceased services. Even we were interviewed in the qualitative about protective measures taken in the facility from the respondents from qualitative study also stated that face mask, temperature measurement, social distancing, and hand washing were the requirements to get any of SRH service in health facilities. However, most of service users mentioned that they didn't want to use face masks. For example, in Amhara region, one in-depth interview participant said that the health facility posted a message at the entrance to wear face mask. Okay, let me continue. Sure. Okay, worries and barriers to access SRH service also try to assess in of the clients also think that we had worries when we say psychological supporters in the facility. In the other thing, the evidence from the qualitative findings also revealed that COVID-19 protective measures, government priority shifting, and fear of COVID-19 infection, both by providers and clients, were the key factors negatively affect SRH service provision and utilization. One CSO or a major representative in the in-depth interview, he said that the restriction at the early stage of a pandemic had significant impact on SRH service provision. Most health facilities were closed, transport services were restricted, healthcare providers were also restricted to go to health facilities. Here in this graph, we try to see even the proportion of clients or women who had not felt safe while receiving SRH services. We try to assess different SRH services. As you can see here, the highest percent of clients who seek MCH, they hadn't feel safe while receiving SRH service during COVID pandemics. Around 61% of clients who seek ANC services, they mentioned that even they hadn't felt safe when receiving this SRH service at the facility. Like for contraceptives, 60%, for CAC, 52.9%, for HIV or AIDS services, 52.9% of the clients mentioned that they had not safe while receiving SRH services during the pandemic. Even we try to see the proportion of service users who rated the most common barriers to access SRH services, which means we try to ask them what barriers was high barrier to access SRH services. As you can see here, they mentioned that around 47% of the clients, our highest barrier was rated like movement restriction was the highest barrier to access SRH service. And around the second highest, around 27% of women stated that providers were too harsh to access SRH service. And the other one, health facilities are too far, is around 20% of the women's mentioned as a barrier, and 15% of clients even mentions that closure of health facilities is one of the barriers to access SRH service. From the qualitative and quantitative findings, we try to identify factors negatively affecting SRH services. So during COVID era, shortage of PP materials, essential SRH commodities, equipment, supplies was significantly affecting SRH service delivery. And COVID-19 related tasks such as screening, isolation, referral, and treatment of COVID-19 cases have created additional workload and adversely impacted SRH service provision. And COVID-19 had also a significant impact on SRH budgets. Key actors of SRH program have shifted significant amount of funding to purchasing and distributing PP supplies for the health facilities. Even in the qualitative finding from the key actors and from NGOs and CSO representatives, we try to assess the incidence of GB, gender-based violence, including harassment, rape, were aggravated during COVID-19 pandemic. The incidence of HIV and STI reported to increase in conjunction with gender-based violence occurrences. Most of the participants in the qualitative study reported that there is an increased incidence of unwanted pregnancy, early marriage, teen pregnancy were observed during the COVID-19 pandemic. Furtherly indicated that COVID has resulted, there are some psychological disorders, anxieties, depression, family conflict, social media addiction, substance abuse, obesity, and overweighting or amongst the community. And they mentioned that at-large students in particularly. And then we tried to see what COVID-19 response measures were taken as a country. So to minimize the spread of COVID-19 pandemic and its effects on healthcare service provision, several initiatives and measures were implemented. PP materials were mobilized, distributed to regional health offices and health facilities. Healthcare providers were also trained on how to handle suspected case of COVID-19. As evidence from provider survey, more than half or 55% of the providers had received training on how to handle COVID suspected cases. And also out of this 55%, around half of them were trained by MOH when regional health bureaus. 34.5% received on-job training by their colleagues, and 11% trained by sub-city health officers. And in addition, SRH service provision guideline developed and approach to service provision adjusted to the context of COVID-19. Implementation guidelines such as service provision harmonization, non-COVID-19 essential health service, RMN self-care interventions were developed, and SRH service were included in an essential health service use guidelines. During COVID-19, several service provision strategies were introduced. Among them, service appointment dates extended for some healthcare services. Number of patients, caregivers reduced in some facilities. Virtual counseling service have been initiated, and waiting area sets rearranged to maintain social distancing. These measures and initiatives helped to prevent COVID-19 and improve SRH service, which had been hampered during the first 3 months of the pandemic. Which means that there is a change after the 3 months. Based on these strategies, in some facilities showed improvements on SRH service provision. But there are also persisting challenges, even till the research is conducted on July 2021, before 3 or 2 months. Still at that time, there is a persisting challenges in SRH service provision. Although several initiatives and strategies devised, some health facilities had still difficulties to accommodate increasing number of SRH service users during the recent period of COVID-19 emergency. Government priorities, focus shifts, discontinuation of support from NGOs, and shortage of essential SRH commodities supplies continue to be key challenges for sustaining SRH service. Stockouts of essential SRH commodities and supplies such as MA drugs, injectables, OCP, PE implants, and IUCD negatively impacted the SRH services. And also most facilities had also inadequate cleaning dispensable, PPE, surgical glove, ICU, beds, oxygen, face mask, alcohol, sanitizer, soap, and some facilities had shortage of hand washing facility and inadequate ambulance for delivery services. This is try to see percent of stockouts of SRH supplies in facilities. As you can see here, around 50% of the facilities reported that in that 3 months when we conduct the research recently, after 3 months, even there is stockout of SRH supplies. This stockout extended from 1 week to 3 months. And also 15% of the health facilities also, they were stockouts of SRH supplies of injectables, and 7% implants, and 9% OCP. Now, I'm trying to conclude and recommend some recommendations. Based on the study, we conclude that the COVID-19 pandemic negatively impacted the demand and provision of SRH services. The pandemic weakened the resource allocated for SRH programming and eroded confidence of health workers to provide care and service users to seek the services, which means decrease their confidences due to fear of COVID, and also clients also decrease our fear of COVID-19. These are our conclusion. As a recommendation, we try to recommend to alleviate the pandemic's impact and sustain a SRH service amid COVID pandemic. Governments, local and international agencies need to mobilize resources for PP materials, essentially SRH commodity supplies, and also these actors, governments, NGOs, local agencies need to work and design new strategies to boost the confidence, motivation, and the capacities of provider to provide a SRH service. And also these actors and all of SRH communities should work, community workers, to improve the service seekers' awareness on COVID-19 and also on its essential SRH services through different community sensitization and through different outreach workers, which means our work should be outreach to the community too. Thank you very much.
Thank you, Samuel, for your interesting presentation. Our next presenter would be Madame Fugidio Jane Hortense. Excuse me if I have misspelled your name, who is an associate professor of obstetrics and gynecology at the University of Yaoundé. And she's also a coordinator of the reproductive and sexual health unit of Yaoundé Central Hospital, which is the biggest Cameroonian hospital. And she has also qualifications in reproductive health research. She got this training from WHO Geneva 2004. And Professor Fugidio is a holder of medical and postgraduate degree in gynecology and obstetrics from Faculty of Medicine and Biostatistical Science of University of Yaoundé. She attended a training in 2005 at University of Libres, Brussels, Belgium. She is also a holder of master's degree in public health from Catholic University of Central Africa. She is an excellent scientist, researcher, author, and co-author of more than 70 scientific articles published in national and international journals in the field of public health, clinical research, and maternal and child health. A professor will join us from Cameroon, Yaoundé, virtually. Brooke will coordinate the virtual communication.
I'm Professor Jeanne Hortense Feugeot, Associate Professor of Obstetrics and Gynecology in the University of Yaoundé 1 in Cameroon. I want to present my work entitled Clinical Management of Rape Cases in Yaoundé, Cameroon, a descriptive study. To present this work, we will follow this plan. We start by a background, then continue with our objectives, materials and methods, results, and conclusion. Concerning the background, we can say that sexual assault is a global health and legal challenge and has been a neglected area of research. Rape is a form of sexual assault, a public health problem, and a human rights violation. The WHO defines rape as physically forced or otherwise coerced penetration, even if slight, of the vulva or anus, using a penis, other body part, or an object. Rape is internationally recognized as a war crime and a crime against humanity, but it's also characterized as a form of torture and in certain circumstances as genocide. It is estimated that approximately 35% of women have experienced some form of sexual harassment in their lifetime. Rape has adverse physical, psychosocial consequences and also devastating effect on the life of the survivors, with long-term consequences on their health and mental well-being. It is associated with an increased risk of range of sexual and reproductive health problems, with both immediate and long-term consequences. Cameroon is not left out as to what concerns this dilemma. A report by Demographic and Health Survey with multiple indicators in 2011 showed that the prevalence of sexual violence amongst females of any age in Cameroon is about 8%. In Cameroon, a protocol has been developed by the state to improve on the care of sexual assault survivors. Therefore, there is a need to evaluate the clinical management of rape in Cameroon. The main objective of the study was to report the clinical management of rape cases at Yaoundé Central Hospital, Cameroon. Our specific objectives was to determine the socio-demographic profile of participants, to describe the clinical aspect of the rape cases, and to describe the therapeutic aspect of rape cases. To achieve this objective, we followed this methodology. The study design was a descriptive one, a prospective study. The study was carried out in 3 referral hospitals in Yaoundé, namely Yaoundé Central Hospital, the Yaoundé Gyneco-Obstetric and Pediatric Hospital, and the Yaoundé Emergency Center. These 3 hospitals are referral hospitals in the Yaoundé town. The study duration was 8 months, from 1st November 2019 to 13 June 2020. Concerning the study population, the inclusion criteria of all age groups received at the outpatient and emergency unit of all our recruitment sites for sexual assault and who gave their consent or their guardian consent. The exclusion criteria was participants of sexual assault who were not rape cases, participants who were suffering from psychological trauma after consenting intercourse. The sampling was consecutive and non-exhaustive. The data collection was done at the consultation areas of survivors who had been received for rape using a questionnaire. The data entry template was created in Epidata version 3.1, and the data was later transferred to and analyzed using statistical package for social sciences, SPSS version 33.0. From this methodology, this is our result. Concerning the socio-demographic characteristics of the population, the major part of our study was female. That you can also notice that we have 1% of men who were affected by the dilemma. According to the age, we can notice that the age group which was most affected was 10 to 15, the age group of 10 to 15. But you can also notice that we have some patients aged less than 5 years, and others and 8% was more than 30 years. Regarding the clinical characteristics, you can note this figure shows that the vaginal penetration was the most frequent one, followed with frequency of 85%, followed by the anal penetration, and you can also notice the vaginal-oral penetration in 1% of cases. The location of lesions was most vaginal lesion. You can understand because the most type of penetration was vaginal penetration. Then we notice more lesions at the level of vagina. We have some cases with lesion at the vulva, particularly on the labia minora or labia majora. Concerning the management of survivor of sexual abuse, we can notice that the HIV test was done in 90.5% of patients who were of our participants. The hepatitis B was done in 80.3% of participants, and you can notice that the pregnancy test was done in 50.4% of the participants. This can be explained by the fact that most of our you can see that this low rate of pregnancy tests can be explained by the fact that our participant was mostly less than 10 years old. On this figure, we can see the therapeutic aspects of our participant. We can notice that antibiotics was prescribed in 44.8% of our participants, and we can notice the antiretroviral post-exposure, which was only prescribed in 43.3%. This can be explained by the fact that many of these participants was received in the night, where this antiretroviral post-exposure, where the drugs are not available at this time. And you can see the rate of emergency contraception. Only 33.8% of these participants receive an emergency participation of emergency contraception. This rate is low because you can notice that a good number of our participants was more than 15 years old. We can notice that almost all our participants receive a psychological care. From this study, we can conclude that rape is common in our setting among infants and adolescents, single status students. HIV, hepatitis B, pregnancy tests, and syphilis were the most common workup prescribed in more than the half of survival. The rate of emergency contraception remained very low. This addressed the issue of unmet need of contraception in our context. We will finish this presentation by acknowledgement to the Scientific Committee of Reproductive Health Symposium and the Organizing Committee of the Reproductive Health Symposium, who gave us the opportunity to present our work. Thank you for your attention.
Thank you, Professor Yaounde. Our third presenter is Muluketa Adele of Jimma University. He is a PhD candidate. He has worked as a lecturer and department head in Debre Tabor University. He has written about 15 articles in the area of sexual and reproductive health. Currently, he is pursuing his PhD in public health with reproductive health track at the Department of Population and Family Health in Jimma University. And his research topic is perception and experience of sexual harassment among women working in hospitality workplaces in Bahar Dar city, Ethiopia, which is a qualitative study. I call Muluketa to the podium.
Okay, thank you, Dr. Gannat, for your nice and generous introduction. And thank you, the organizers, for giving me this chance to present this important topic for this symposium. Actually, I was in a clinical area for about 4 years, and I tried to do abortion service for lots of girls in hospital, and the women or girls from hospitality workplaces were the second next to students to just come for abortion service. And we wrote, me and my friend actually discussed about the assessment of hospitality workplaces regarding workplace sexual violence, and we wrote a grant for CERTITIP, and we got a grant for that, and we realized that sexual harassment is a mostly prevalent case in the most prevalent case among sexual violence in workplace. And we revised the current researches in Ethiopia, and we did systematic review, and we got that there is no study conducted in hospitality workplaces in Ethiopia. So we just selected the topic called measurement and understanding and measurement of sexual harassment in Ethiopia. So we try to do systematic review, and we got that sexual harassment is the most prevalent. But so this topic is sexual harassment, the perception and experience of sexual harassment among women working in hospitality workplace. And as you know, at this time, actually, we should have to start from the good news, and the world is looking a better place for women due to decline in early marriage, increased involvement of women in leadership and politics, and gender equality by reforming legislations. And around 39% of women were included in the workforce. Despite their this achievement, they continue to face challenges regarding with their reproductive health rights and associated things. And workplace sexual violence is among these issues, and this is the most serious one. And according to our systematic review, in Ethiopian workplaces, sexual violence is the most prevalent one, and it is not yet addressed in hospitality workplaces in Ethiopia. So hospitality workplaces are increasing, where women are enrolled and than men, and the job is precarious. Sorry. So women are disproportionately affected by workplace sexual harassment due to their working status, the type of work they do, and the conditions in the field they work. And the issue may also harm their safety, health, and well-being, and emotional, psychological, professional, and health-related effects can occur. And it results in high cost, especially in low and middle income countries. And this is a global problem because of young and minor employees are there with income instability, stress and dependence on supervisors and managers and customers. And the working in low and middle income country hospitality industries are particularly unorganized and vulnerable. Thus, well-established social assets, including social networks and tailored reproductive health knowledge, are needed to decrease workplace sexual harassment. There are differences in understanding, experience, perception, and risks and implications based on factors such as gender, background, and perceiver ideology. And the workplace sexual harassment is still debatable and unsettled problem worldwide, especially in low and middle income countries. And precarious jobs, sexual objectified environment, and tolerance of sexual harassment, psychological safety climate, and complaint procedures have also been related to workplace sexual harassment. And there is still gender, context, and ideology-based disparity in understanding experience, coping, and other related issues. So some research is focused in Ethiopia, some research is focused on effect of workplace sexual harassment on mental and behavioral well-being, employment, and physical health. However, the reproductive health effects such as workplace harassment, sexual harassment, such as transactional sex practice, commercial sex work, STIs, including HIV and menstrual disorders, are rarely recognized. And the problem deters women's capacity, which nearly mobilizes half of the world's business and endangers nearly all the international agendas. So the initial misconception should be eradicated and need to have the belief that sexual harassment prevails everywhere and not yet sufficiently addressed. So in Ethiopia, there are two proclamations, Proclamation 414/2004 and Proclamation number 1156/2019. These they just suggest some sort of imprisonment for the perpetrator. However, hospitality were identified as hotspot areas in the systematic review in Ethiopia. The hospitality workplace in Addis Ababa, I mean, by Melako Adar, it is the employees are identified as MARPs, and the hospitality workplace is identified as a hotspot area for HIV. So it is a problem, that means. However, most initiatives to mitigate reproductive health issues such as HIV, unsafe abortion, and unintended pregnancy did not include workplace sexual harassment. Thus, this study aimed to explore women's perception and experience with workplace. So the method, the study setting was Bahar Dar City, which we thought that it is a representative for other places because there are lots of hospitality workplaces there, and the study design was exploratory method. It's part of, actually, as I said, it's part of an exploratory sequential mixed method design. And phenomenology is a type, and in-depth interviews, focus group discussions, and key informant interviews were the the data collection techniques. And the study participants were women employees with more than 6 months working experience in hospitality workplaces. Women identified and contacted using snowball method after we identified the first women purposefully, and NGOs, community workers living in the city help us to reach them. And key informants were recruited purposefully, and the key informants were the managers, the cashiers, and the customers, and the co-workers. And the enrollment of the study participants was continued until the data saturated. And the sample size was actually based on saturation. And data collection was from January 1 to August 30, 2019. And the information was gathered through a variety of methods and sources, as I told you. So I'm sorry for the visibility. The data analysis tried to follow the exhaustive techniques of thematic analysis, and we tried to transcribe, we tried to just read the transcriptions in detail, and then prepare the transcriptions for analysis. Then we tried to just check the transcriptions and enter to the software. And we try to be familiarized on the transcriptions, generate initial course, search for themes, and then review the themes and define the themes to just create code books. And at the end, we try to produce the report. And then we gave the report to our colleagues who has been involved in data collection for as a replacement for member checking, and description of the process was done for the advisors and for the colleagues, and description of the context has been done. And to ensure the studies quality, we try to, this is actually, for credibility, for the trustworthiness of the study, we try to, in addition to the exhaustive process, we tried to interview the interview, and the FGDs were edited and modified by qualitative research experts, the facilitators of the FGDs, and key informants, and the data collected from female hospitality employees, supervisors, cashiers. It means triangulated. So regarding the results, 29 documents were there, and 58 participants were there, and the participants, 6 FGDs, 10 IDIs, and 13 key informant interviews were there. The average length of record was 80 minutes for the IDIs and FGDs, and 40 minutes for KIs. And the female age was like this. So for the sake of time, I tried to reduce the quotations, and you can get it on BMC Publicans, already it's published, and you can get the whole information there. It's an 18-page manuscript. So after we did lots of things in the analysis and the process, we got 4 major themes, and the themes were perception of workplace sexual harassment, experience of workplace sexual harassment. These are the titles actually, and our aim was to address this, but based on the interviews and key informants information, we tried to include the perceived risk factors and the consequences. So the perceptions were pressuring, threatening, touching, and abducting. They perceive that sexual harassment, workplace sexual harassment is pressuring, it is threatening them, and it's touching them and abducting them for some sort of favoring. And the experiences were verbal, non-verbal, and physical. And the perceived risks, they just mentioned that the perceived risks were customer-related, victim-related, organization-related, society, peer policy-related, and work-related. And the consequences, health-related, work-related, and financial and family-related. So regarding the perceptions, why will they talk about the pressuring? They told us that there were exaggerated tips. This is to pressure them to just engage in some sort of sexual favors and inappropriate promise of rewards in exchange for sexual favor. Regarding with threatening, the perpetrator just threatens them to hurt women's relatives and fire from the job, falsely accused about the provided service to the immediate supervisor for unless they agree to be to just for the exchange of sexual favor. And touching sexually sensitive parts of the body was one of the perceptions that they mentioned. And the other is abducting, raping, slapping, kicking, pinching, and verbal insult. This is actually different from the definitions that were mentioned in other countries, developed countries, in the Western countries. Regarding with their experiences, they just told us that there were verbal experiences like catcalling, non-verbal experience like unwelcome gestures of sexual nature, and physical experience like unwanted touching or sexual contact. And we asked them who were responsible for all these activities, and they mentioned that customers were the most mentioned, and supervisors, managers, and owners were the next, and agents, brokers, and transactional sex practitioners were there. They told us, let me underline the transactional sex practitioners. The sex practitioners, by the way, commercial sex workers while their market is failing, they went to the hospitality workplaces, cafeterias, restaurants, and bars. And they invite, they are willing to just do business even in that places. And due to the perception of the customers that there are commercial sex workers or transactional sex practitioners there, they perceive that all the women present in hospitality workplaces are commercial sex workers or transactional sex practitioners. So that is a risk. So, and they are also the agents. Transactional sex practitioners are the agents for the customers to just bring someone to just commit something. And the agents are also the untouched part, actually. Agents are the most mentioned perpetrators of workplace sexual harassment. And as I told you, the perceived risks, and as I told you, the customer related are, they perceive that all the employees are transactional practitioners, commercial sex workers, and ordinary sex objects. They perceive that all the things are there and interested in related sexual matters and easy to get employees for sex. They perceive that these are the easy things. And the victim related, as I told you, there are transactional sex practitioners and other things. And organization related, they just uniforms. The uniforms are driving forces, as they told us. The uniforms are and the clothing or that show their body, breasts, buttocks, and something, and sexually attractive clothing, and uniforms that show their thighs and something. And the society's perception, they perceive that hospitality workplace employees are commercial sex workers. They perceive it like that. And peer sexual pressure. Peers are agents even in that place. And lack of strong government strategy was the things that they mentioned. The lack of professional associations who worry for them was the other issue. And the lack of organizational policy was the other. So let me tell you the issues that they mentioned as consequences. And work-related consequence was one of the mostly mentioned issue. Job hopping, including job hopping is changing job to other or just decreasing their motivation or something. So they changed their job, they changed the locality to work, they changed, they were late to their work and something, their motivation was decreased and they become coffee sellers around the roads or beside the roads. And health related, they faced mental and behavioral health problems, physical health problems, reproductive health related problems, as they mentioned. And they faced financial problems and even their families were undermined due to their work. And these are the health related aspects, but let me underline the reproductive health aspects. They told us that after they face workplace sexual harassment, they face menstrual disorders and they participate in sex trade. Without their interest, they were pressured to sex practice. Say transactional sex practitioners, and they will change themselves to commercial sex workers. Abortions were there, unintended pregnancy, and they acquired STIs, and including HIV. So, as a discussion, actually, we perceived that the workplace sexual harassment was not well understood by the employees, women employees in hospitality workplaces, and we just try to search literatures, and they just mention the same findings in their findings, and we suggest the orientation of employees, even there should be a trained waitress there, because the waitresses should have to have a degree, should have to have a diploma, and they should have to be enrolled in a university, and they should have to know about workplace sexual harassment before they will be enrolled in hospitality workplace workers. And our study showed that the women's hospitality workplace employees' perception of it is different, as I told you. Women employed in hospitality industry face various types of, as I told you, verbal, non-verbal, and physical harassment, and established several factors, as I told you. So it's consistent actually with other studies, but and the term signify current social dynamics functioning within the hospitality workplace setting and women relationships with customers, co-workers, agents, and immediate bosses. The behaviors and perceptions discussed suggest actionable areas for improving hospitality workplaces, efforts to support women employees and prevent workplace sexual harassment through interventions, some interventions. So by providing female employees practical support and security and promoting gender equitable attitudes among employees, customers, co-workers, and immediate bosses, the hospitality workplaces can be a stepping stone rather than a hurdle towards females' realization of their full potential. And organizational workplace sexual harassment related policies and strategies should have to be developed and implemented. And hospitality workplaces should formulate in consultation with Ethiopian law and labor relation experts to improve workplace sexual harassment policies that could change deep-rooted beliefs and norms. So for the future, actually we did it. The coping techniques should have to be investigated. So we investigated and you can get it online. And we're actually working on the associated factors and consequences and to generalize for the general community. And if someone wants to be interested, if someone is interested to work on this field, it's an open area. So as a conclusion, there remains a wide diversity of opinions regarding the meaning of workplace sexual harassment, actually. And women employees face various forms of workplace sexual harassment types. Mention different perceived risk factors and consequences, and workplace sexual harassment is a norm that creates a culture of hesitation and other unintended outcomes, which may endanger more health and organizations' performance that seeks healthcare and prohibit productivity. It may cause further rise in women's psychological deterioration as long as social, moral, and legal norms are not harmonized. So coordinated efforts from the hospitality industry, non-governmental organizations, governmental agencies, other stakeholders, and sexual and reproductive health organizations, specifically, customers and female employees are needed. So thank you very much.
Thank you, Mulgeta, for your interesting presentation. Now I call upon Samuel and Mulgeta to the stage and Professor on virtual for questions, comments, and suggestions. If you have questions to all the three presenters, you are welcome. Okay, Dr. Spy. Okay, you can continue, Dr. Spy.
Okay, thank you very much. Very interesting presentation. Congratulations all the presenters. It was very fascinating. And it was a timely presentation. So I have one question for Samuel and one question for Mulgeta. So Samuel, on your finding, you said psychological disorders, depression, obesity, overweight. You mentioned some of these things have increased on your report. So can you tell us a little bit how this data was extracted, or how do you get this information? Was it from qualitative piece or quantitative piece? How did you extract this information with your design? And Mulgeta, very interesting finding. I think sexual harassment at workplace. I think you showed us a tip of an iceberg. I believe the findings are could be similar in other settings. So, and also I'm glad that you did a literature search and see that an evidence is lacking in this area, and then you go back to undergo a qualitative study in your setting. It was a very fascinating finding. Congratulations again. Saying this, I think you mentioned the sampling method as a snowball method. So what was justification to use that sampling method? And if you tell us a little bit more about how you included your participants, if you used any specific inclusion criteria. Thank you very much.
If you have heard, okay.
Okay, thank you very much. Thank you all for the presenters. I do have a question and a recommendation for Mr. Samuel. Impact of COVID-19 response on our rich care service provision and utilization. I was expecting to see the effect of COVID-19 response or effort. But all the findings you presented are the impact of COVID-19 on our rich service, but not the response. This might be, I couldn't understand what is the main objective of your presentation. And the other thing, around 76% of participants worry about MCH service. There are a number of MCH service. Which MCH service? There are maternal health services, there are also child health services, but 76% of MCH services worried or worried about getting this service. And the other thing is, are you going to, did you evaluate the challenges, the pre-existing challenges, or only challenges related to COVID-19 for the provision and utilization of COVID-19? Because there are a number of challenges, pre-existing challenges, which is not related with COVID-19. So are you going, did you evaluate all the pre-existing challenges or only related COVID-19 challenges? This is the other concept. Thank you very much.
Dr. Magdas?
Thank you very much. I have one question for Mulgita. You were thank you very much for your interesting article. So when you do this research, was there an ongoing harassment, or because you were telling us about sexual violence to the extent of rape and also consequences? So if you find this kind of employees, what were your actions at those moments? That's one of it. The other is hospitality areas are different, starting from small bars to like 5-star hotels. So where was your focus, and have you seen any difference between those different hospitality areas? Thank you very much.
Thank you, Dr. Magdas. If we don't have further questions, the presenters may respond. I start with Samuel.
Okay, thank you very much for your question. All questions are very interesting. I'll try to respond as my understand. Like the first question was, how did you get the psychological disorders and some increasements of obesity and anxiety, something like that? Actually, this finding is obtained from the qualitative study, but it was not from the one qualitative. For example, in some situations, the same questions may be asked from, okay, hello, okay. The same questions may be asked for state actors, NGO representatives, and also in the in-depth interviews. But the main technique was qualitative study. In that study, I think at least into techniques, these things mentioned during this pandemic, it was increased. The other question, your research is impact of COVID-19 and also the impact of COVID-19 responses. Yeah, we try to address both. They are almost related. Actually, they are different, but we try to see the findings, both findings. As you can see from the findings, even the responses. As a response, even the movement restrictions and some service date changes, service extensions also as a challenge. It was a challenge. So it's impacted the SRH services. So in this research, we try to show both things, the impact of COVID-19 and also the impact of COVID-19 responses. MSH, sorry for this, we just try to say delivery services, MSH. Delivery clients who are coming or seeking delivery services, the highest, they had highest worries when taking SRH services. Did you evaluate with other challenges? Actually, this is good questions, but our research main objective was try to see the persisting challenges related to COVID-19. So only take these questions, and if we continue this research, we try to evaluate with other challenges. But in this research, we try to identify the challenges related to COVID-19. Thank you very much.
Okay, thank you very much for your questions. Actually, they are important because we are ongoing, even though it's published, we do have some quantitative parts continuing, and we are going to, it will be an asset for that research. So regarding the snowball sampling technique, Dr. Tesfaye, we did, as I told you, we did a convergent technique for the assessment of workplace sexual violence among waitresses in Bahar Dar. At that time, we realized that the waitresses or the women in hospitality workplaces were not easy to get. They just want something to be available for the research to respond for us. So we try to involve the NGO workers there. Mahabara Hiwat was there in Bahar Dar. So they gave some sort of training. So we tried to communicate them, and they told us that it is difficult to get them. So it's better to just, they know each other. So it's better to just get a person first who had experience. They told us a person, and we went there and we just asked that woman first, and we just asked her to just bring some other women who had similar experiences. So one of the reason was, as I told you, the difficulty to get the women who experience sexual harassment there. And the other is, we realized that there are women who didn't have experience. As I told you, in the assessment, in our previous assessment, only around 46% of women respond that they had some sort of workplace violence, especially workplace sexual harassment. So we realized that there are women who had no experience. So we tried to get those who are experiencing the event. That's why we try to just get the first woman purposefully and went to snowball sampling them. And the other is regarding is the inclusion and exclusion criteria. In order to just remove the recalling bias, we tried to just ask women who had experience of 6 months and above in hospitality workplaces. And among them, we tried to just, first we tried to just exclude women who has been working at kitchens and something. But after some time, we realized that even the women from kitchen are experiencing sexual harassment. So we included them. And except the experience, we didn't exclude anyone. And regarding these ongoing actions while we did our research, actually I didn't mention the ethical issue here for the sake of time, but as I told you, Mahabara Hiyot, they were doing some sort of activities regarding with commercial sex workers, and they connect them with health institutions, even for psychological support in some institutions. So they were with us, and for some of them were crying while we asked them. So in such situations, they helped us in connecting them with other psychosocial supports, but it was not as such exhaustive, because even the services are not as such strong around Bahar Dar to support women from hospitality workplaces. And as I told you, the society perception was also one of the challenge. And regarding with the difference between hospitality workplaces, actually the qualitative part didn't give us some sort of difference in around the hospitality workplace, such as restaurants, cafeterias, bars, and something. But the quantitative that we investigated before showed us that cafeterias are the workplaces where high workplace sexual harassment was present. But in order to check whether which institution is relatively high burdened, we are just doing another assessment, because that assessment was simply for prevalence. So we're going to do a multi-level analysis. Actually, we collected the data, and I think you will get it soon. Okay, and so we didn't get any difference in hospitality workplaces, but they mentioned that high star hotels, 5-star, 4-star hotels are relatively ethical. So there is some sort of regulation regarding with the distance between the customer and the employee. So the 5-star and above hotels, 4-star hotels are relatively good in terms of reducing workplace sexual harassment. If there are other things that I didn't understand, you can forward. Thank you.
Thank you so much. For the sake of time, we will wind up the session at this point. We thank all the 3 presenters, and the next presenter will be the same.
All right, thank you. So I would like to thank Dr. Gannet for moderating the session, and presenters for their nice presentation. We still have 2 oral presentations. So those oral presentation will be moderated by Dr. Magdas Baru. Dr. Magdas is a graduate of Mekelle University. She completed her OBGYN special training in the same university, and she is currently doing her fellowship in family planning and reproductive health at St. Paul Hospital Millennium Medical College. So a faculty at St. Paul Hospital. So I will upon Magdas to moderate the presentations. Thank you.
Thank you, Dr. Matthias, for the introduction. So I'm going to call upon two presenters who are going to present their research. For us, the first one is Mr. Yosef Wasihun. Mr. Yosef Wasihun is from Bahar Dar University. He has a master's in public health. He has 7 publications until now, and he has 3 years experience of teaching in public health, and currently he has more than 3 years experience in working in Bahar Dar University. His research topic is on determinants of second trimester safe termination of pregnancy in public health facilities in Hamara region, Ethiopia. And the second presenter who is going to follow Mr. Yosef Wasihun is going to be Dr. Abraham Abebe. Dr. Abraham Abebe obtained his degree in medicine from Jumma University in 2015. Currently, he's an obstetrician and gynecologist. He got his certificate for obstetrics and gynecology from St. Paul Millennium Medical College. He served as a general practitioner for 2 years in Assa Hospital before he joined his residency program in obstetrics and gynecology. And over the past 6 years, he has been involved in preventive and curative services rendered in those institutions. His research topic is knowledge, attitude, and practice of healthcare workers toward the safe abortion and its associated factors at tertiary health facility in Addis Ababa. And it's a cross-sectional study. First, I call upon Mr. Yosef Wasihun to the stage. Thank you.
Thank you, Dr. Magdas, and thank you, the organizing committee, for preparing this symposium with the challenging time. And I'll go to my presentation with behalf of our colleagues. And the title is Determinant of Second Trimester Safe Termination of Pregnancy in Public Health Facilities in Amhara region. These are the presentation outlines. When it comes to the introduction part, as you know, abortion is the termination of pregnancy before 20 weeks age in developed countries and extended to 28 weeks in Ethiopia. Second trimester abortion is the termination of pregnancy between 13 and 28 weeks. Some researchers dictate starts from 12 weeks. And the burden of abortion is still high, being one of the leading cause of maternal mortality and morbidity. Globally, about 42 million abortions are performed annually. 10 up to 15% are second trimester abortion. From the second trimester abortion, over half of which are considered unsafe. When it comes to the African case, 3 out of 4 abortions that occurred in Africa were unsafe. In Ethiopia, prevalence of abortion among women was around 9%, from 4.5% in Benjangul to 11.3% in Tigray. In case of Amara, it's in line with the national figure, it's 9.5%. And between 2008 to 2014, the percentage of abortion performed in health facilities increased from 27% to 53%, but still this much figure is occurred outside of the health facility. Evidence showed that the prevalence of in the second trimester abortion was 11% in Ethiopia. About 97% was abortions are unsafe. And in Amhara region, the prevalence of second trimester abortion was 19.2%. That's why we are interested to conduct this research on this title. Maternal mortality is still high in Ethiopia, and 19.6% occur due to abortion complication, especially in case of second trimester abortion. The complication is still challenging. About 92% of African women live in countries which is restrictive for abortion law, and in Ethiopia, termination of pregnancy is permitted where a continuation of pregnancy endangers the health or life of the woman or the child, and pregnancy is a result of rape or incest for up to 28 weeks gestational age. When it comes to the objective of our study, just to identify the determinant factors of second trimester safe termination of pregnancy in public health facility in Amhara region. All right, from methods and materials part, this study was conducted in Falagayot Specialized Hospital in Bahar Dar City and Gondar University Comprehensive Specialized Hospital in Gondar City, Gondar Town, and Devra Marcos Referral Hospital in Devra Marcos. Actually, we assessed the performance of these hospitals, one-year performance, and we took the 3 months average performance. When you see the performance, monthly performance, for example, Falagayot is around 40%, 40 abortion takes place every month. And in Gondar, around 117 abortions took place. And from Devra Marcos, around 35 abortions, safe abortion took place. And when you come to the study participants, all women who came for safe abortion care were study participants. Women came in the second trimester, 13 up to 28 weeks, considered as case, and women who came in the first trimester, less than 30 weeks, is considered as controls, and we use EP4 to calculate the sample size considering 1:2 ratio and power 80% or the ratio 2.2, and we use a factor residence, and the percentage, the proportion of rural among 49% among cases and 32.2% among controls, and include non-response rate of 10%. The final sample size was 357. All right, participants were allocated proportionally for these 3 hospitals, and we use a systematic random sampling technique, and a structured interviewer administered questionnaire was used to collect the data. The questionnaire was adapted from previous researches. When it comes to the data analysis part, the collected data were checked and entered using EP data, and analyzed using SPSS, and to identify the independent predictor of second trimester termination of pregnancy, we performed multivariable regression and adjusted odds ratio and p-value less than 0.05 were considered for declaring the significant factors. All right. From the ethical view, the purpose of the study is already explained for the study participants. Written and oral consent were took from the participant, and ethical clearance was obtained from Bahar Dar University. Come to the result and discussion part. A total of 347 participants were engaged, around 110 cases and 237 controls were included, with a response rate of 97.2%. About 40% of cases and 68% of controls were urban residents. Around 43% of the case and 32% of the controls were under 20 years. about 68% of the case and 67% of the controls were single, and about 52% of the case and 38% of the controls were students. Participants' information came to abortion care service, about 36% of the case and 22% of the controls had no check for pregnancy till the abortion services given. And for 55% of the case and 36% of the controls had regular menses history. About 77% of the case and 90.3% of the case had opposition for abortion care. And about 77% of the case and 51% of the case have information about the law of abortion. They have information. When it comes to the factors that determine the second trimester of abortion, rural residents were nearly 2 times more likely to conduct second trimester self-termination than urbans, and supported by a study conducted in Ethiopia and India. Probably the limited health facilities for abortion care service in rural areas and the risk perception to abortion could be the justification. This reason is already raised from this study. And in this study, second trimester self-termination of pregnancy was more likely in those who were a low level of educational status, special primary school, and than the diploma and above. And this result is in line with a study conducted in Kenya and Zambia. The reason could be as educational level increase, the knowledge of the participant increase, and the probability of safe abortion increase. That is first trimester abortion. I think it is audible. And when you come to the participants who had irregular menses, were nearly 2 times. Participants who had irregular menses were nearly 2 times more likely to conduct second trimester self-termination, and supported by a study conducted in Canada. However, a study done in Zambia showed irregular menses has no association with the irregular menses. And in this study, participants who did not know the signs and symptoms of pregnancy were nearly 2 times more likely to conduct second trimester self-termination. Lack of awareness may lead to late seeking termination of pregnancy. And participants who had delayed referral, where the more strong factor is 10 times more likely to second trimester self-termination than participants who had no delayed referral. Another determinant is participants who did not know abortion law were 3 times more likely to conduct second trimester self-termination of pregnancy than those who knew the abortion law. And the result is supported by studies conducted in Harar and Oromia region. And participants facing opposition against abortion care were nearly 3 times more likely to conduct second trimester self-abortion compared to those who are not. These studies also agreed with studies done in Brazil, but this finding was not in line with a study done in Zambia. The possible reason may be the difference might be due to educational status level and cultural difference. Also, participants who had not performed pregnancy tests at the early time were 2 times more likely to conduct second trimester self-termination. And this result is consistent with a study done in Canada. The reason could be that women may know may not know the presence of pregnancy test. This reason is surprisingly raised in a study conducted in Britain. These are the factors, and they come to the conclusion and the recommendation part. This study found many determinants that contribute to second trimester safe termination. And those factors are the main factors that we identified. And when it comes to the recommendation part, just we recommend based on this finding, the Mara Regional Health Bureau should give emphasis to women living in rural area, because still the facility is not properly giving the abortion care, and they are exposed for second trimester abortion. They should increase awareness about this abortion law, about signs and symptoms of pregnancy, and about irregular menses. And higher level educational should be encouraged by Educational Bureau. Health facilities that have no abortion service should refer early to the accessible health facility. This is an acknowledgement, and these are some of the reference. Thank you very much.
Thank you, Mr. Yosef, for your timely presentation. Now I call upon Dr. Abraham for his presentation.
Thank you. Thank you, Dr. Makras, for your generous introduction, and the scientific committee to create this opportunity for me. And thank you for to have this opportunity and to present my first research in front of my teachers and giant researchers. Okay, thank you, sorry. So my thesis topic is knowledge, attitude, and practice of healthcare workers toward safe abortion and associated factors at tertiary health facility at Addis Ababa, Ethiopia. And these are my outlines of my presentation. And as you know, safe abortion is performed by, it's defined as it's a procedure performed by a capable personnel, which is medically conductive environment, which is defined by WHO and the technical and procedure of the Ethiopia. And nearly half of all abortions, almost 21 millions of abortions are unsafe. And out of this, nearly 98% of them are performed in developing countries. And as a single agent of, as a single problem of maternal mortality, 30% of the causes are secondary to the unsafe abortion. And the health risk of safe abortion is dependent on whether the procedure is being performed safely or unsafely. And the healthcare workers' knowledge and practice to safe abortion is not only for the initiation of the procedure, but also it will significantly decrease abortion complication. So when you see the rationale of the study, the healthcare providers are the most important role in the provision of abortion service. And however, the shortage of these healthcare providers in low-income countries is critical, but which is maybe exacerbated by the unwillingness of some healthcare workers to provide this service. So some of these, since there is no similar studies published in our study area, and those who are studied in the country are inconsistent, and they are not include all healthcare workers, and they are not studies as associated factors. So this study will contribute for the as a baseline for the information of the future studies and plan policymakers in the health care workers, and it will give also a great benefit as a reproductive health committee in general. So my objective of the study, general objective, is to assess the knowledge, attitudes, and practice of healthcare workers in the associated factor at St. Paul, and the specific objectives are to assess the knowledge, the attitude, and the practice and its associated factor of the healthcare workers. And when you see the method, it's a study was conducted at St. Paul as one of the tertiary hospital under Ministry of Health, and it gives a service to around 200,000 people annually. And also it gives, other than the other specialties, it gives service in obstetrics and gynecology, especially it provides abortion and family planning service, and annually around 1,500 women get access for safe abortion. And the study design is hospital-based cross-sectional study, and it was conducted between May 1 and to July 30, 2021. And the source of population are healthcare workers who are at St. Paul, and the study populations were those who are health workers working at OBGYN department. So the inclusion and exclusion criteria are also addressed. So the sample size was, the sampling technique was, the sample size was determined from the previous study, similar study. It was calculated for the knowledge, attitude, and practice, the largest sample size was taken, and it was 0.5. Accordingly, it was because the population was below 100,000, it's taken a simple size population formula, and considering 10 non-response rate, and by stratified these healthcare workers according to their profession, it was convenience sampling was taken to select its subjects, and the variables were also well determined. And data collection, the study was conducted using pre-tested self-administered structure questionnaire, which was adopted from previous study, which was also addressed the specific and the general objective of the study. And this was collectively, with the data was collected by 2 midwives and at OBGYN department, which was taken as OPDs and the wards, and data management and quality control was assured with each data collector was trained on the interviewing, and information was retrieved when filling questions, and the data was also the data collector also assures each data after the filling, and the data process was after the data items have been coded. The coded questionnaires was entered into SPSS version 23, and descriptive statics and logistic regression analysis was done, and bivariant analysis was carried out to see the association of each variable, of which p-value of 0.25 are taken to the final model, and the result was interpreted with figures, the tables, and the confidence interval, and these are the words which are operationally defined. And ethical consideration was also with ethical clearance, and permission letter was taken from the IRB of St. Paul with this reference letter. And informal consent was taken for each respondent during the participation period, and the privacy and confidentiality was also safeguarded throughout the study course. And then when it comes to the result and discussion part, around 199 self-administered questions was distributed. Out of these, 187 were completed, and the response rate was 94.4. And among the respondents, majority of them are females, and they within the age group of 25 to 29, and the average age was 27. So when we see the parameters with the knowledge associated with healthcare workers, so majority of the health workers, around 73.8 of respondents have a good knowledge, which was when it was compared with other results, it was better than the others, like those which was the one which was studied at Addis Ababa Health Center, which was 2053, and it was comparable with a study conducted in Asala Teaching Referral Hospital. And when you see the associated factors with the healthcare workers' knowledge towards safe abortion, the mean knowledge score of midwives and the medical doctors had higher than, more like are good knowledgeable than the nurses. So we got the healthcare workers level is affected by the knowledge. So this was a level. So that when you see the attitude of healthcare workers towards safe abortion, more than half of the respondents have a positive attitude, which is also similarly comparable with the study conducted in the Adama facility, but which was lower than the Asala Teaching Hospital, because it could be the reason is the study population is different, and the study subjects are also different. So the associated factor with the knowledge, the attitude of healthcare workers is the respondents' year of experience, and the religion has got significantly associated with the study. So when you see the practice of healthcare workers towards safe abortion, around half of the respondents have a good practice, but which was also lower than that of the Asala referral associated study. And the associated factor with the practice of the respondents were the level of professional and the age of respondents had been significantly associated with the practice of the healthcare workers. So the strength of the study is the study has no similar studies are conducted in the other studies. So the other thing is the association between the variables has been also determined, and the study area, as you know, it is a tertiary hospital, and there are a lot of cases and experienced physicians. So it was good, but the limitation is because this is a cross-sectional study, and there was social disability behavior bias, and participants were from one study. But if it's better, it's included in the other private institutions. So the conclusion is majority of the respondents had a good knowledge in our study area, and half of them are healthcare workers have also positive attitude to safe abortion and good practice. And majority of the healthcare workers also are not trained on safe abortion, and being the level of profession is also associated with knowledge of the knowledge for the respondents, and having clinical experience more than 3 years, and being Muslim who are also studied on significantly associated with providers' attitude towards safe abortion, and age more than 25 also as being, and being medical doctor has been influenced the practice of safe abortion care. And my recommendation on depending upon my studies, the provision of training on healthcare workers, specifically for nurses, are highly important to improve the safe abortion practice, and involving the nurses, midwives, and other professions in the activity of safe abortion service might improve the care. And efforts should be also done to improve the healthcare knowledge, attitude, related abortion, and pre and on service training. And the participants are from one study, so the studies, another studies might be needed to see the other. And I will acknowledge my study participants, my department, and my advisors on the scientific committee to create this opportunity, and my wife. And thank you.
Thank you, Dr. Abraham. So I call both the presenters, Mr. Yosef and Dr. Abraham, to the stage if there's any questions, so that like you can reflect. Thank you. If there are any questions, you can raise.
Okay, thank you very much. Thank you for both of the presenters. It was a very nice, timely, and a very much related topic. So I want to congratulate you again on your work. So my question is to Mr. Yosef. I have comment as well as question, and my comment or kind of my input is on the background information. Some of the references that you used are a little bit outdated, and it's good to include more recent figures. For example, in terms of contribution of abortion to maternal deaths, the recent figure shows much less than 19%. Sure, 19%. It's now even less than 10%. So, and the other is even the contribution of second trimester safe abortion is also much lesser. So it's, especially if you are preparing the manuscript for publication, I suggest you to use more updated information. And also in the definition of abortion, it's good to use more standard references like World Health Organization definition of abortion. And my question is, so based on your study, it looks like the comparator is second trimester and the comparator is first trimester. So it do have a number. So when you're saying some of the outcomes are more common in the second trimester, I suppose the comparator are first trimester, right? Or there needs some clarity there when you talk about, some of the outcomes are more in second. For example, more of patients in the second trimester are from urban, then I consider the others are first trimester, right? Or is all second trimester abortion cases? So that probably if you can clarify this more, or if all participants are second trimester, we want to hear more about this. And the other thing is, second trimester, as you described, it's a wide spectrum, starting from 13 weeks up to 28 weeks. So a woman coming for safe abortion at 40 weeks is different than a woman coming for safe abortion at 26, 27 weeks. So you try to do, subgroup analysis within the second trimester because it has a different implication. I think this is all I have. Thank you.
Thank you very much. My question goes to the first presenter, and one of my two questions actually has been mentioned by Dr. Tesfaye, was about the control group. What makes it the first trimester being the control group of second trimester pregnancy? Is it because the standard of abortion should be in first trimester, or is it because second trimester is it a problem? Like, do you think it's a delayed, it's a delayed management of pregnancy? And my second question would be, I want to learn from you if pregnancy intention could have been contributed to delay in pregnancy, to having a second trimester abortion. I mean, pregnancy intention, I mean by primarily intending to get pregnant, but later on, the woman does not want that anymore, because I probably missed it from the data. Thank you.
Okay, thank you very much. My question goes to Mr. Yosef. First, thank you both presenters for your nice presentation. My question, I think you employed logistic regression, like second trimester, yes and no. I miss something like, what are the control groups? Are you trying to compare first, second trimester and first and second trimester, which means that you are trying to determine determinants of abortion trimesters or determinants of second trimester. Did you compare like second trimesters, women received the second trimesters, and the control group, women didn't receive any kind of safe abortion? Or did you compare the first and the second? Even I didn't get the comparisons of the case and control in, as my understand, the outcome variable is abortion trimester, yes and no. And you are comparing or you are determining abortion, the factors affecting or determining the abortion trimester. Let me get some explanation on this area. Thank you.
Thank you. Any more questions for Mr. Muluketa and Mr. Abraham?
Okay, thank you both presenters for your informative presentation. And having said this, I want to just forward my first question to Mr. Yosef. As you mentioned, most of the study participants had no pregnancy test for abortion. So how did they confirm whether that is second trimester or first trimester abortion? And the second question is, you mentioned that both controls and cases did not, who did not know about the abortion law were there to just commit abortion, second trimester abortion. Where did they get the information unless they know the abortion law? And what do you recommend on this issue? And the second question is for Dr. Abraham. Sorry. I appreciate actually your effort to conduct this type of study. I know that it's your thesis. You mentioned that it's your thesis. But I've seen some sort of issues which can just lead to question the credibility of your evidence. The first thing is actually related with your sample size. Your sample size is 199. It has been better if you consider healthcare providers from other institutions and make it at least the minimum sample size, because I've seen huge precision. The confidence interval is huge, from 8.6 to 104. That's a huge precision and huge confidence interval. This is due to your sample size. And the other thing is, your data collectors were midwives, isn't it? And your participants were gynecologists, general practitioners, nurses, and even midwives. So how did they check, the data collectors, how did they check the practice part? How did they collect the data? Did they observe? Did they use a checklist? How? And the other is, in your conclusion, you mentioned religion. Mostly in studies, religion was the missed part actually. We don't want to just say anything about religion because it can lead to bias. How can you justify this? How can you discuss this? So it's better if you didn't send it for publication, it's better just to consider these things. Thank you.
For the sake of time, okay.
Okay, thank you, both presenters. My question to Mr. Yosef is, in your result session, you have indicated that opposition against abortion care has a number of 2.6. What does this indicate? Are women who have opposition against abortion and still willing to participate in the abortion care or obtain the service? What's the indication? And for Dr. Abraham, in your method section, you have indicated that you used convenience sampling and you have a response rate of 94.4. How could that, align? If you took convenience sampling, there shouldn't be such kind of response rate and the like. And the second question is in relation to religion, because this is a sensitive issue. The Muslims were having less knowledge with an adjusted odds ratio of 0.29. And medical doctors and being midwives is having a great chance of being knowledgeable. So have you done any subgroup analysis with the profession, with that of their religion, which is like in the form of strata? Otherwise, it would be a harsh conclusion. But I second the questioner who has raised the issue of credibility, generalizability, and any other issues, because this is not supplied with sample size determination, and we can talk about CAP and associated factors. Thanks so much.
That's going to be the last question.
Okay.
Try to make
Thank
it
you.
short.
I would like to thank both presenters for your nice presentation. But I do have a question only for Dr. Abraham. How you control social desirable bias, especially professional desirable bias on your study? That is my question. Do you think all these three dependent variables is very important? Especially the knowledge part may be distorted by professional bias. That is my suggestion. So why you didn't triangulate? Did you address really attitude issues by simple quantitative study? Why you didn't add some sort of qualitative in attitude? That is my suggestion. The last one, I will share my colleagues' questions about sample size, which is manageable. Why you calculate sample size? Why you calculate sample size? Because it is manageable. The other thing, it's maybe modifiable, but you didn't check the interaction of your dependent variables. For example, knowledge can affect attitude. Attitude also can affect practice. Those three variables can affect each others, but I didn't observe anything unless on this finding on research. Thank you.
Okay, thank you for the questions. First, I will give the chance to.
Thank you, Dr. Magdas. I will respond some of the questions. Actually, I will miss some of the questions from the audience because I didn't hear some of the questions, but what I have, I will respond. I will take the comments as a comment, especially out-of-date reference. Probably I will correct it. Actually, this paper is already published, so we will update. This study is not a comparative study, rather it's a case control study, so consider it. Mainly, the question is that first trimester abortion and preferable than second trimester abortion, or is that second trimester abortion is bad than first trimester abortion? I think so. It's clearly if they arrive early, it's better, as we dictate. The complication is more from the second trimester abortion. Yes. So if we are this at first trimester abortion, so we can decrease the complication. But the question is, when they increase the gestational age, probably the unwanted issue of the pregnancy may be arise, so they can abort at second level. Yes, I accept that. But the thing that the first trimester is preferable for aborting. And I said they didn't check the pregnancy test till till they came to the hospital for abortion care. So I think not all, but some of the cases and some of the controls reported this issue. So don't confuse with the cases and the controls. We consider cases less than 13 weeks. Cases are there that we want to address. The cases are the cases are 13 up to 28 weeks, and the controls are less than 30 weeks. So 13 up to 28 weeks are challenging than the controls less than 13. So we can determine the factors. There is no outcome, but our intention is identifying the factors that delay the women for first trimester abortion, not any clear outcome. Rather, identifying the factors that makes the participant delay for second trimester abortion. So this what I have. Probably I'll turn back if missed.
Thank you. Thank you. About the issue of sample size, yes, it was right. But during the data collection, and it was a COVID pandemic time, and we did the study in the department, and the total number of the physician in the department was known, it was 344. That's why I didn't take the whole size, and I calculated from that by using correctional formula, and I took 199. Otherwise, if it is, it was better if taken the whole. I accepted that part. And the practice questions, yes, it should be done with checklist during the procedure time, because the practice should be assessed with checklists. That was not done, and I will accept that part. And the religious part, I accepted the comment, and I will correct. And about the professional disability and the issue of the non-response rate, yes, this convenience sampling is, as you know, it was non-random, non-probability sampling, and it was prone for desirable bias. And I extended the data collection time for 1 month and 2 weeks, and it was collected curiously, and the sample size was, the response rate was 94.4. And the association between dependent and independent variables, and it was not projected on this slide, but I did the correlation between the dependent and independent variables. What was the finding was there was association between the knowledge and practice, attitude and practice, but there was no association between attitude and practice. But it was not projected on this slide, but it was included in my paper. And thank you, I already accepted the comments.
Probably one question from what do you mean by 2.5 times opposed by opposition groups? So those women opposed by their relatives, whatever, delay for second trimester abortion, then who have support to abort their pregnancy. That's the point, not comparing the case and the control. Rather, we are revolving around the case, not the controls. So those have support to terminate the pregnancy is less likely to delay for second trimester abortion.
The audience for your question, and also the presenters for your answer. I think we are done in this topic.
Okay, thank you, the presenters as well as moderator. Before breaking, I would like to take a moment to thank our sponsors. So our gold sponsors are Center for International Reproductive Health Training, CERT Global, Engender Health, and the David and Lucy Packard Foundation. Our silver sponsor is IPAS Ethiopia. We thank all of them for the generous support to make this symposium a reality, and also above all for all the work they do to improve the lives of women and girls. So we'll take a 10 minutes break, and we'll come back after that. Thank you. Welcome back. We'll continue with state of the art lecture. So the state of the art lecture will be moderated by Dr. Lami Balai. Dr. Lami is a medical doctor, assistant professor of OBJ and family planning and reproductive health subspecialist. He is a researcher, trainer, academician, and reproductive health and justice advocate. He has published more than 30 publications in reputable international journals, and he has actively participated on production of different reproductive health guidelines, protocols, and training materials. He's serving as Ethiopian representative of World Association of Trainings in Obstetric and Gynecology, WATOG. Dr. Lami is currently serving as a consultant and clinical vice chair of Department of OBGYN at St. Paul Hospital Millennium Medical College. So I will call Dr. Lami to moderate the session. Thank you.
Thank you, Dr. Matthias, for your kind introduction. So now is the time for state of the art lecture, and it will be given by Dr. Farid. Dr. Farid is an OBGYN with specialty training in family planning and reproductive health. He is currently working at St. Paul's Hospital Millennium Medical College as Associate Professor of Obstetrics and Gynecology. Farid has published several research works in international reputable journals. He worked in the guideline development group at World Health Organization, Geneva. He's also serving as a focal person of Ethiopian Society of Obstetrics and Gynecology for the technical working group on family planning at Ministry of Health. Farid has special interest in postpartum family planning and the provision of complex contraception for women with medical comorbidities. Dr. Farid will give us a state-of-the-art lecture on bilateral complete self-injectomy, a paradigm shift in female permanent contraception. So I will welcome Dr. Farid to the stage. Please, the stage is yours.
Thank you, Dr. Lami, for the generous introduction. And I also thank the symposium organizers for inviting me to give this state-of-the-art lecture this afternoon. So today I will be talking about complete bilateral self-injectomy and this role as a method of permanent female contraception. So I have no conflict of interest to declare. And this afternoon, I will just take you the next 10 to 15 minutes to talk about female sterilization and the role of bilateral self-injectomy as a method of female sterilization. So why are we interested in permanent contraception? Okay, so there are a number of factors that we should consider when we give counseling for contraception. One is the perfect use, which is going to be translated to efficacy. Okay, when we say perfect use, we're saying how women are using this contraception in a controlled research setting. But when you say typical uses, when people are using the contraception in their day-to-day life, and this will translate into effectiveness. So there are a number of variables that affect effectiveness of a contraceptive method. So efficacy is one of the variables that's going to affect the effectiveness of a certain contraceptive method, compliance to that contraceptive method, and continuation. Okay, these factors directly affect the effectiveness of contraception, whereas fecundity and coital frequency and timing may inversely affect the effectiveness of a contraceptive method. So for permanent methods, the typical use and the perfect use are almost always similar. So as you can see from this slide, female sterilization, the failure rate of female sterilization is usually comparable, be it is perfect use or typical use, unlike other contraceptive methods, including the long-acting reversible contraceptive methods. So the other reason that we should be, giving more emphasis to the permanent methods is the national targets. Ethiopia has set out a very ambitious goal in 2012 for the FP 2020. And the aim was to achieve a contraceptive prevalence rate of 55, okay? And the last PMA data we have is the contraceptive prevalence is about 37%, and the unmet need is still very much lagging behind the target. So the Ministry of Health has adopted a national RH strategy, which ended last year, and a new one is still under development. But they emphasized the opportunity to use large method and permanent methods to fill the gap in terms of achieving contraceptive prevalence and decreasing the unmet need. So, but the reality is different, okay? So only 1/3 of women in Ethiopia are aware of about female sterilization. And again, the utilization rate of female contraception in Ethiopia is very low. I'm sorry about the slide, okay? So in Ethiopia, it's just about 0.4%, okay? So South Africa, for example, has the female sterilization rates about 7.7%. So as you know, female sterilization can be done during postpartum, post-abortion, or interval. I'm pretty sure most of the female sterilization done in Ethiopia are the postpartum period. We rarely have interval sterilization techniques, especially nowadays. It's not becoming a very common procedure. The other is the approach that can be done. Laparotomy, again, I put here during, because when we do laparotomy, we're going to do BTL. It's very unlikely that someone will go laparotomy just for the purpose of doing tubal ligation. Laparoscopy is a new emerging technique. Mini-lap, again, this is used to be one of the common procedures, at least in developing countries, for doing tubal ligation. Hysteroscopy, again, this is no longer practiced. The issue is out of market for so many reasons. So it's no longer being provided as a method of female permanent contraception. So now, why should we consider bilateral self-injectomy as a means of female sterilization? Well, we have to answer these three questions. Okay, one is how effective it is compared to the normal tubal ligation that we have. What is the added benefit or value by doing bilateral self-injectomy compared to the usual BTL, and how safe it is and how feasible it is to do self-injectomy compared to the tubal ligation that we used to do. Okay, so when you talk about the effectiveness, you have to address how effective is normal tubal ligation that we know. Okay, so one of the very important study in assessing the effectiveness of tubal ligation is the CREST study. This is a landmark study that was done in the United States. They have more than 10,000 women enrolled. This is a prospective study, and women were followed for more than 10 years, 8 to 14 years, okay? So the failure rate of tubal ligation was, or female contraception, was about 18.5 per thousand procedures, okay? So this is a very important study because it also informed us the failure rate also relates to the method it was provided. So as you can see from this figure, those interval postpartum tubal ligations and unipolar have the lowest rate of failure compared to the bipolar and the silicone and rubber. Okay, so now we know the method of tubal ligation really matters in determining the failure rate. Okay, so not only the failure rates, if failure happens, then it's the likelihood of having ectopic pregnancy will be higher. Okay, so the overall rate of ectopic pregnancy in this study was about 30% and 20% for postpartum. I will be focusing more on postpartum because more or less this is going to be what we're going to have most of the time in our setting. Okay, so in those who have failed tubal ligation that was done during the postpartum, 20% are going to be ectopic. So now this is going to put bilateral self-injectomy in a very tough spot because we already have something very effective. Okay, so now we have to compare bilateral self-injectomy with tubal ligation that we used to do. Okay, so the problem with this is bilateral self-injectomy is just something that is being introduced nowadays. It's not a very common procedure, and we don't have many high-level evidences to assess the effectiveness of bilateral self-injectomy as compared to bilateral tubal ligation. So this was one of the systematic reviews that was conducted last year. It had 6 randomized control trials, and 5 of them were included in the meta-analysis. And there was no difference in most clinical outcomes. In these clinical outcomes, they look for estimated blood loss, the need for blood transfusion, the duration of hospitalization, reoperation, and in total, the need for transfusion and hysterectomy. So there was no difference between the 2 groups. And there appears to be the rate of pregnancy appears to be lower after bilateral self-injectomy compared to tubal ligation, but this was not again statistically significant. Another study looked at women who had bilateral self-injectomy, and initially they were looking at the rate of spontaneous pregnancy after bilateral self-injectomy done for indications of sterilization, hydrosalpinx, or PID. They intentionally excluded women who had bilateral self-injectomy as a purpose of treatment for IVF. Okay, so those studies were those women were excluded, and they identified only 4 cases of spontaneous pregnancy after bilateral self-injectomy, and all pregnancies were intrauterine, unlike where the rate of ectopic pregnancy was higher in other cases of bilateral tubal ligation. Yet there are still many limitations for this, because none of the studies were randomized controlled trials, none of the studies were prospective studies. So they had to look for case reports and retrospective studies, and this was the best evidence. It was published like two months back. So now we have seen the effectiveness of bilateral self-injectomy, and we have to focus again, what is the added value, okay? So the added value now is bilateral self-injectomy can actually reduce the risk of ovarian cancer, okay? So one study reported about 49% risk of ovarian cancer. Again, this is among general population. This is not specific to women who are already at risk of ovarian cancer because of genetic mutations. This is among the general population. And again, even the risk reduction is even better compared to women who had bilateral tubal ligation. So the risk reduction by doing bilateral self-injectomy was significantly higher than compared to those who had BTL. So having this evidence, both the American College of Obstetricians and the Society of Gynecologists have accepted and adopted that the bilateral self-injectomy should be discussed as a method of sterilization, and they have endorsed even this for women who are at average risk, that the bilateral self-injectomy should be offered as a mode of sterilization. So now, what is the safety then? Okay, so as we said, most of the tubal ligations that we do is at the time of cesarean section. So we have to look at how safe is bilateral self-injectomy done at the time of cesarean section. So one of the studies that reported is 8 minutes longer when you do bilateral self-injectomy than tubal ligation. And again, this was statistically significant again, but think of it in terms of clinical significance. This is just 8 minutes. So even though this may have statistical significance, clinically, it may not be that much important for us. And there was no difference in terms of the surgical complications, in terms of blood transfusion, intraoperative complications, hysterectomy, and prolonged admission to the hospital. And one of the concerns for long was bilateral tubal ligation versus bilateral self-injectomy. Self-injectomy may lead to menstrual irregularities and quality of life and regret. That was not significantly different between the 2 methods. Another randomized controlled trial also looked at the success of completion. Obviously, completion was a bit higher when compared to when we do tubal ligation compared to self-injectomy. And again, the statistical significance is the duration of time. It took 15 minutes longer to complete self-injectomy compared to bilateral tubal ligation. And again, the most clinically important outcomes for probably most clinicians is the adverse outcomes. That was not significantly difference, and providers were more satisfied with BTL. So a recent large systematic review and meta-analysis of randomized controlled trials showed the total operative time was slightly longer when doing bilateral self-injectomy compared to BTL. And this was about, the mean difference was about, again, 5 minutes. This was, again, statistically significant, but may not have a significant clinical importance in our daily practice. The rate of complication was not different between the two, and the need for blood transfusion, the need for or the difference in terms of estimated blood dose was not significant between the two. So basically, the safety is within the acceptable range for clinical practice. So the other time where we can consider doing bilateral self-injectomies at the time of laparoscopy, a few centers are in Ethiopia are doing bilateral self-injectomy or in general laparoscopic surgeries. Again, this was not significantly different when you do BTL versus self-injectomy at the time of laparoscopy. The difference is the number of ports that you will use. If you are doing only tubal ligation, you will use 2 ports. But if you have to do tubal ligation, you will add 1 more port just above the bladder. Okay, but the trend is somewhat different. Okay, so in US between 2015 2018, the rate of changing from bilateral tubal ligation to bilateral self-injectomy is amazing. So in those 3 years, there were about 3.8 million cesarean sections. And of this, 10.5 had bilateral self-injectomy, which is twice the amount of bilateral tubal ligation. And the rate of change, as you can see, is for bilateral tubal ligation it's dropped to 2.4, whereas the bilateral self-injectomy have rise to about 30%. So as you can see, now the current figure is in the US. The shift is significant, and just mid 2016, there are more bilateral self-injectomies done than bilateral tubal ligations for the purpose of female contraception during cesarean section. So again, ACOG have accepted this. Okay, this again, I have to go back to this data. This data is till the end of 2018. So 2019, there is an ACOG recommendation that self-injectomy can be considered at the time of hysterectomy or at the time of tubal sterilization, and it is safe and does not appear to have increased risk of complication. But they did not make a bold statement with regard to its safety during cesarean section. So it's still an open room for discussion. And again, the risk-benefit of self-injectomy should be discussed with the patient once they have decided for permanent sterilization. So thank you. This is what I have. As I said earlier, St. Paul have started doing bilateral self-injectomies at the time of laparoscopic procedures. We have done successfully for a few cases, and so in this video, we demonstrate why bilateral self-injectomy being done for a woman who have completed her family size and were counseled for bilateral self-injectomy as an option of female contraception, and that's what we did for this patient. Okay. If you have any questions, the floor is open for discussion.
brief and clear lecture. So the floor is open now for question and answer.
Thank you very much, Dr. Farid, for the nice presentation and lecture and the updated information. I have one question. How do you see the applicability of bilateral self-injectomy widely, like in our country? Before, partial self-injectomy or bilateral tubal ligation should be given, used to be given as a training with mini lab, even for mid-level in that health workers, along with like non-scalpel vasectomy. So in most researches which are done in the US are laparoscopic surgery. So how can we like adapt this to our setup so that like we can have the added benefit, the less failure rate, and also like the decreased ectopic pregnancy from bilateral self-injectomy? Thank you very much.
Thank you very much, Dr. Farid. It was a very uplifting presentation. So my question is, if you say a little bit more about, the applicability of this new technique in our setup, especially considering that most of our BTL is done during cesarean section, which is an emergency one with general anesthesia. So how is the applicability of this evidence on the face of emergency cesarean section with general anesthesia, where we want to minimize the time of the surgery in order to reduce the operation time? And the other thing is, can you say a little bit more about, counseling the procedure, because this is a new technique and more evidence are emerging. How should a clinician, counsel a patient while, doing a new procedure? So if you say a little more about these two questions, thank you.
Thank you, Dr. Farid. It may be an odd question, but I think you can excuse me because I'm not a gynecologist. Just curious. I heard that this bilateral tubal ligation, even if it is a permanent contraception, there is a thought that if the woman changes her mind, there is a slight chance to reverse it with microsurgeries. But if you do self-injectomy, that may be difficult. So what do you say about it? It may be odd, but I think you can react.
Okay, Dr. Tade.
Okay, thank you very much, Dr. Farid, for briefing us about this permanent contraceptive method. So I just want to have some comment on bilateral self-injectomy during cesarean section. I think sometimes when you see a paper from the Western world and taking that really to our setup, we have to be really very careful. So especially in the teaching centers where most cesarean sections are being done by residents, the postpartum period, how much the pelvis is vascularized, the areolar tissue which were really avascular, okay, how much it is vascularized, and sometimes just puncturing the broad ligament will lead to a huge retroperitoneal hematomas and so on. So when you recommend such things, really we have to be very careful with experienced surgeons, gynecologists and so on. That is quite all right to secure the hemostasis and so on. but the you know, the complication difference. Rate, okay, what we see with the cesarean section, really hemostasis is somehow not as such easy. So we have to be very careful, and we have to introduce these things really very carefully, okay, by having more experience and so on, training our residents and so on. So otherwise, bilateral self-injectomy, there is no question. Now that is a standard when the tube is no more needed. The other thing, the mini laparotomy. So nowadays, if you consider permanent contraceptive with tubal ligation, so bilateral self-injectomy is definitely the preferred one, and it is well documented. So when you come to the technical part, okay, with mini laparotomy, you know what you have to do is just simply you hook, okay, the tube and then do the self-injectomy at the mid, the part of the tube, okay, bilateral tubal ligation, usually with a Pomori technique. So what do you say with the bilateral self-injectomy with mini laparotomy? Do you have any literatures? How is the technical difficulty or easiness? So the other thing probably in our setup, what we have to see is, you know, our mothers are quite very young when they have, okay, multiple deliveries, okay, and they are fertile when after even giving birth for 7 children and so on, in their 30s and so on. So what do you see the regret rate, okay, for in such communities when with mothers with advanced age and so on? That's all right. But from the experience, what I myself has seen is, you know, in their early 20s, they have already delivered 5, 6 children, and they consent for permanent method. Finally, when they are in their 30s again, okay, because of various reasons, especially the social impact, okay. So these mothers really request for further fertility. So what do you say this? Thank you very much.
Thank you very much, the audience. I think very nice questions are there. Just to begin responding with the questions, I just want to pop up some question for Dr. Farid. And depending on the title, let's say it's a paradigm shift. What is this paradigm shift? And previously, it was it said like an opportunistic self-injectomy. So, would you please say something on this paradigm shift and answer the question from audience? Thank you.
Thank you all. These are all important and interesting questions. So I will start. Some of them are related, so I'll just try to briefly discuss them all. Okay, so the issue of doing self-injectomy at the time of mini-lap. When it comes to mini-lap, it's very rare to find studies from the Western world on mini-lap. Some publications from Southeast Asia, India, and Pakistan have a lot of figures on the safety and complication rate of mini-lap procedures. Even in the CREST study that was done in the early 90s in the US, mini-lap was not even a method of doing bilateral tubal ligation. Monopolar, unipolar, bipolar, the silicon band, the postpartum and the interval tubal ligations were included in the review, but mini-lap was not a standard of care in those studies. So at this moment, I don't have any reference that discuss about doing mini-lap for the purpose of bilateral self-injectomy. So I will not be able to give you a concrete figure on that, or in terms of the safety or feasibility of doing it. The other is cesarean section, given that most of the cases are done emergency and general anesthesia. In general, for all bilateral tubal ligations, for all permanent methods, counseling should come first. it's not going to be feasible to have an informed consent taken in a woman where we want to do emergency cesarean section. It's going to be very tough to say it is actually an informed consent. Okay, if we want to do it permanent method at the time of delivery, then the discussion should happen way before she went into labor and during the antenatal period. That is the ideal situation. But there are some reference materials that compared. Actually, this was an internal comparison. A woman who had unscheduled bilateral self-injectomy, and the complication rate was not significantly different compared to those who had scheduled bilateral self-injectomy. So by principle, it's better to avoid permanent methods in a condition where there is a need for emergency. The other is reversibility. Okay. So yes, in the past, reversibility of tubal ligation used to be considered as an opportunity. Microsurgery, so microsurgery now they put it as it's more of an attitude than an actual procedure, the way how you handle the tissue. So, you know, there's the recent recommendation in someone who already have bilateral tubal ligation and have changed their mind, is the recommendation is to go for IVF, okay, which will also be done in cases where women have already bilateral tubal ligation or self-injectomy. There is still a possibility of going for IVF. In fact, if a woman have tubal pathology and she's not getting pregnant because of her tubal pathology, the recommendation is to remove those tubes and go for IVF. So still IVF is going to be an option. The success rate, even with tubal reversal, is going to be very much low, and the success rate in terms of getting pregnant, but it doesn't assure that that pregnancy will be intrauterine. There is a high chance that pregnancy is going to be ectopic, so the recommendation is going to be go for IVF. So yes, I think we need to really look at our settings and the resources that we have in case something goes wrong. Okay, so I will not suggest doing bilateral self-injectomy just right away from now onwards. We need to have a lot of things in place before we move in that direction. And again, even the SOG have left some room. They didn't make any strong recommendation for doing bilateral self-injectomy at the time of cesarean section. The last study I displayed, the 3.8 million women who had bilateral self-injectomy or bilateral tubal ligation after cesarean section. In that study, they reported a higher rate of blood transfusion and a higher rate of hysterectomy. But again, they specifically mentioned this was not controlled for confounding factors, so they could not make a strong recommendation that self-injectomy is associated with hysterectomy, but that absolute number is related. Again, the percentage was 0.4 in those who had bilateral BTL versus 0.8 versus who have self-injectomy. So even though the absolute number is low, when you compare the two, it is different. So again, the mini lab, I think I have addressed that. Age and parity. Okay, so the regret, again, I would recommend everyone who is doing female permanent contraception to look at the CREST study, because they have looked at what are the determinants that patients may end up having regret. Okay, one of the factors, in fact, the most important factor for regret after tubal ligation is the age of the patient. It was not parity. So even if a woman is para 6, para 7, and if she ends up having tubal ligation at a very young age, it's likely that she may end up having a regret. So when we counsel patients about permanent methods, regardless of their parity. So that counseling really matters when it comes to giving an informed decision. So again, it goes back to the discussion that the patient and the physician are having regard to the choice of the method that the patient is making. Let me question, okay, what is a paradigm shift? So the paradigm shift, I think we can describe it in two things. One, the understanding of ovarian malignancies has changed. In the past, ovarian malignancies were considered it is because of the repeated ovulation, But now the thinking is, well, it is the tubes that are leading to a higher number of ovarian cancers. In fact, these studies came from women who had prophylactic self-injure oophorectomy. What they found was the tubes which have these called stick lesions, serous intra. So the abnormality will be detected first on the tubes, while the ovaries were entirely normal. So they had that impression. It is probably the distal tube that is first affected and goes to the ovaries. So that understanding of the pathogenesis of ovarian malignancies have changed. But what the other thing that's changed is how lenient providers are in doing self-injectomy versus BTL. As you can see, the shift in practice came even before the recommendations by ACOG and other relevant bodies. So I think the community, the medical community is jumping on whatever evidence is available, even though that evidence is not very high level evidence to recommend one versus the other. So these are the two paradigm shifts that we are seeing. I think we can put it in a way that the rate of pregnancies after bilateral tubal ligation or self-injectomy are not significantly different. But what is different is its protection against ovarian cancer. So it's like, you know, having two birds with one stone, but one of the birds is way larger than the other.
Thank you very much, Dr. Farid. If there are any burning questions, I will give a chance for 2 persons only. So if there is no further question, thank you, the audience, for active participation, and Dr. Farid for your nice response.
Thank you, Dr. Farid, for the state of the art lecture, and Dr. Lami for moderating the session. Next is award ceremony. So I call upon Dr. Tadas Urge, who is chair of the award committee for this symposium, to announce winners of the award. And also I call upon Dr. Matame Bekkala, who is director of the research directorate at St. Paul Hospital, Millennium Medical College, to give the awards. Thank you.
Okay, thank you very much. So now we are coming to the end. So with the name of the award committee, I will announce the winners. So there are 2 awards. So the first one is the Best Oral Presenter Award. And this will go to Mulgeta Delay, Perception and Experience of Sexual Harassment Among Women Working in Hospitality Workplace in Bardar City. So the second award will be the Best RH Researcher Award for 2021. So this goes to Dr. Daraja Baisa. Dr. Daraja Baisa is an associate professor at St. Paul Millennium Medical College. He did his bachelor degree in nursing from Haromaya University, master's degree in maternity and RH from Jimma University, and got PhD from University of South Africa in reproductive health. He published 33 different articles in reputable journals, and 25 of the research is around sexual and reproductive health. So, Dr. Daraja Baisa.
Okay, thank you, Dr. Tadessa. So we have come to the end of our symposium. So I want to give the chance to Dr. Matama Bakala to give closing remarks. Thank you. So certificate has been prepared for all presenters as well as moderators. So we'll give it at the end of the session. Thank you.
Thank you very much. I would like to say congratulations for the Department of OBGYN and the St. Paul Institute of Reproductive Health for this extraordinary achievement in preparing an annual conference. This became a trend in the department and in the institute, and I hope this will be contagious and will go for the other departments as well. So this is a wonderful thing. We learned a lot of things. Such conferences are important to disseminate our findings, to get some learning issues and others. So I would like to congratulate again. And there are 3 points that I want to raise in this particular time. One thing is everybody, especially the clinician, should learn to engage ourselves in doing researches. So, you know, there are a lot of challenges, especially for a clinician, including the time, the demanding time, especially those who are practicing both in the OR and in the clinics. We know that there is a challenge in addressing the issue of time, because we need to have this time with the family, we need to have this time with the patients. But still, if our heart is toward research, we will get a loophole to do that. So that should not be a kind of excuse to ourselves. So I encourage everyone to get engaged in research. The other important thing, there is no shame in doing a mistake, because if you are considering ourselves as a learner, then we can make a mistake. As a resident, as a medical student, we have been doing a mistake. We have been given some comments, and we remodeled and reached to this stage of consultant and other things. So we are not yet graduated. We can't be graduated from life. So one of the definition for a medical doctor is he's a lifelong learner. So as far as we are learning, there is no shame in making a mistake. So as you can see, some of the papers are published. Still, we are giving a comment. So still, we can learn from our own paper. So I encourage everybody to get engaged in doing research. The second is, don't put your research in the shelf. So publish it, come to a conference, present it, and learn, and also let others benefit from your research work. So dissemination is important. Unless we are disseminating our research, there is no point in doing the research. And the final thing is, our clinical practice is now being very much integrated in multidisciplinary team work. There is no single physician who is treating a single patient. Leave alone across the departments, even in the same department. Now, the gynae ops department is an example to have multiple subspecialty. Now you go and sit for a single patient and you discuss the case. So the same is true for research. We have to come together. The public health and the clinician should come together and do the research in a better way. Otherwise, it becomes meaningless. But if you are doing together, then we can challenge a policy and we can change it. So I encourage to do a collaborative work. So finally, I have seen so many good researches which are coming. And again, I would like to say congratulations for successful conduct of this annual conference. Congratulations.
Thank you, Dr. Mahatma. Maybe before we leave, I want to mention a few people whom we are very grateful, and the symposium couldn't be possible without their hard work and dedication. So my team at St. Paul Institute for Reproductive Health and Rights have been doing all the background work. I'm really grateful to have such a wonderful team with me. So thank you so much. Dr. Brook has been galvanizing the IT work throughout the process. We are very much grateful to have his with us. Dr. Delayo Bekele and all the OB/GYN department team, they have been helping this process starting from 5 months back. We are very grateful for them, and also the scientific committee, the organizing committee, the fundraising committee. We are so much grateful. And I also want to thank our funders for making our event so much attractive and beautiful. So as you can see, this is the third one, and the third one is, much more wider than the second and the first one. We have participants even outside of Ethiopia. More participants are coming from countryside, from different regions, and also even from outside Ethiopia. So I believe we are growing more, and this platform will continue to grow. So thank you, everyone. Thank you so much. Hope we'll see each other next year with the same platform. Thank you so much. So you can take the certificate as your way out. Thank you.